Welcome to this special training on COVID-19. My name is Jim Hood, and I'm a paramedic with Victor Farmington Volunteer Ambulance, and I'm pleased to be able to share this important information with you. A download of this PowerPoint, including notes, is available for you to follow along with and for future review. The COVID-19 pandemic is a severe public health challenge and will undoubtedly affect EMS. I hope this training helps our paramedics and EMTs to understand this disease and improves the standard of care for our COVID-19 patients. I'd like to take a moment to thank my wife and children for their support of my volunteer ambulance activities. Mike Carlotta, Jared Palmer, and Rob Merkel, our leadership at Victor Farmington, for their expertise and suggestions. Dr. Ryan Brecker, our medical director, for his expert oversight of our agency and his review and input for this training. And thanks to other professionals who were kind enough to provide feedback and expert consultation supporting this training. Dr. Kayla Dewey from the University of Rochester Medical Center, Dr. Vashi Srivasan from the University of Cincinnati, Patricia Fioravanti, Senior Nurse Case Manager at Rochester Regional Health, and John Kuppinger, who practices nursing at the University of Rochester Medical Center and is a paramedic at Monroe Ambulance. I'm indebted for their support. This training will cover a number of important topics with the intent of providing our paramedics and EMTs some background information on coronaviruses and COVID-19 in particular, a sense of what you will be facing in the field and what it will look like from a perspective of patient history, risk factors, and signs and symptoms. We will review key patient assessment tools and COVID-19 indicators and differentiators. COVID-19 is highly transmittable by both airborne and contact routes, so we will be reminding everyone of PPE and cleaning precautions. We will review applicable collaborative protocols for patient care, and we'll specifically discuss some protocol modifications and considerations specific to COVID-19. COVID-19 is a novel coronavirus. Novel literally means new. Since COVID-19 is newly discovered, research and protocols are changing rapidly. The situation is dynamic and developing. While I include specific figures from reliable sources, remember, these are based on new research. The key takeaways are the trends and indicators. Always monitor trusted sources of information and stay up to date. Some important web links are listed here, and this presentation contains references for important information, which are included as endnotes. As always, follow collaborative protocols and medical direction. Coronaviruses were first discovered over 50 years ago in 1966 in London, England. They were first imaged in 1970 by the United States Department of Health. The photograph on the left is that first picture, and you can clearly see the corona of protein spikes around the viruses that give them their name. Coronaviruses are spherical, single-stranded, non-segmented, positive-sense RNA viruses characterized by spike proteins projecting from the viron surface. Now that's quite a mouthful, so let's break that apart. Spherical, they're round like a ball. Single-stranded and non-segmented. This means that the entire genome of the virus is contained in a single strand. Compare that to, say, humans, who have a multi-stranded, segmented genome contained in 23 pairs of chromosomes. Positive sensed. This is an RNA, or ribonucleic acid virus. Positive sense simply means that once the virus RNA infects a host cell, it can immediately hijack the cell's protein production and force the cell to reproduce viruses. There are no intermediate steps required. It probably won't surprise anyone that coronaviruses cause respiratory and gastrointestinal diseases. Some of the first coronaviruses discovered caused the common cold in humans. Coronaviruses are classified into 4 general categories: alpha, beta, gamma, and delta coronaviruses. Historically, they were categorized by the antibodies they would produce, but now they're classified by their actual genetic lineage. Coronaviruses are both zoonotic and human pathogens that infect the respiratory and GI systems in mammals and birds. As illustrated in this diagram, bats and birds are important vectors for cross-species infection and virus mutation. Coronaviruses are large as viruses go and hold the title as the largest known RNA virus. The RNA genomes of coronaviruses can be up to 32,000 bases, or nucleotides. Because coronaviruses have such large genomes, their mutation rate is lower than other RNA viruses, about half that of other viruses. But these viruses have another way of mutating. When a host becomes simultaneously infected with 2 or more coronaviruses, the viruses can exchange RNA and form a new, novel coronavirus species. This illustration is the family tree of the coronavirus family. The alpha coronaviruses are the red branch, beta are the blue branch, gamma the green branch, and delta the violet branch. I'll point out a few familiar coronaviruses. On the alpha branch, coronavirus 229E and NL63, and on the beta branch, coronavirus OC43 and HKU1 are the viruses that everyone watching this presentation has probably experienced once in their lifetime. Most people call these viruses the common cold. In the blue beta coronavirus family, we find MERS, or the Middle East Respiratory Syndrome coronavirus. The MERS outbreaks in Saudi Arabia and South Korea in 2012 and 2015 had a 30 to 40% mortality rate. The good news is that COVID-19 is only distantly related to MERS. Also in the blue beta coronavirus family is SARS, or the Secure Acute Respiratory Syndrome coronavirus. SARS was first reported in Asia in 2003 and was followed by a global outbreak. SARS symptoms included diarrhea, a dry, non-productive cough, and hypoxia. SARS was a serious disease. 20 to 30% of those infected with SARS required mechanical ventilation, and about 11% of those infected died. SARS was eradicated in 2004. There hasn't been an identified case since. COVID-19 is in the same family tree branch as SARS and is similar genetically and, not surprisingly, in terms of symptoms and presentation. Let's zoom into the branch of the family tree containing SARS and COVID-19. This is a close-up of the same SARS and bat coronavirus branch that we were looking at in the previous illustration. Here we can see that COVID-19 is more distantly related to SARS, which is at the top of this illustration. SARS and COVID-19 are more like cousins. COVID-19 is most closely related to a coronavirus that infects bats. In fact, COVID-19 is so closely related to one of these bat coronaviruses that they're nearly identical twins. So let's learn some specifics about the COVID-19 coronavirus. When you read through the literature, you'll find a number of different names for novel coronavirus 2019, or COVID-19. It's also listed as NCOV-19 for novel coronavirus 2019, SARS-CoV-2, indicating it is the second severe acute respiratory syndrome coronavirus and related to the first SARS, and HCOV-19 for human coronavirus 2019. They're all names for the same thing, and you may see the other names used in this presentation, depending on the paper that published the information. They're all COVID-19. COVID-19 spread through aerosol droplets and contact. Viral replication occurs in the lower respiratory tract. As I mentioned before, these are large viruses as viruses go. They're about 125 nanometers in diameter. That means if you lined a bunch of these up back to back, it would take about 4.9 million viruses for you to make a 1-inch line. COVID-19 has a 29,891 nucleotide-based genome. This is huge for an RNA virus. And COVID-19's genome is 96.2% identical to bat coronavirus RATG13. COVID-19 is more distantly related to 2005 SARS, sharing a 79% base nucleotide match. The primary cellular host receptor is the angiotensin-converting enzyme 2, or ACE2 receptor. This should cause some flashbacks for the paramedics, as they recall the renin-angiotensin system, an endocrine system for controlling blood pressure and regulating fluids in the body. The renin-angiotensin system converts the hormone angiotensin-1 to the vasoconstrictor angiotensin-2. Many of our patients take ACE inhibitors as a treatment for cardiovascular disease. The COVID-19 virus is exploiting the ACE2 receptors on the human cells and using them to unlock and enter the cell to infect it. The ACE2 receptor is mainly expressed in the lungs on alveolar cells. This is why the lungs are the primary organ for COVID-19 infection. The virus is literally infecting and destroying alveolar epithelial tissue. There is also some unfortunate news. COVID-19 seems to have a nasty superpower. It may act against parts of the human immune system. Lymphocyte counts in COVID-19 patients, especially T lymphocytes or killer T cells, are not elevated like in a normal infection. They're low. Researchers also found that patients with more severe COVID-19 infections also had lower numbers of helper T cells. Surviving helper T cells in infected patients are, however, very active. These patients had very high levels of inflammatory cytokines, which are produced by the helper T cells. So the cytokine evidence makes it look like the remaining outnumbered helper T cells are putting up a pretty hard fight against some foreign pathogen. The understanding of COVID-19 incubation is still developing. COVID-19 has a longer incubation period than a lot of other viruses, such as influenza, and this may be because of the way COVID-19 suppresses the immune system. The average patient will begin experiencing symptoms about 5 days after exposure. Most patients will have symptoms within 11 days, and the 99th percentile for symptoms is 14 days. Said another way, only about 100 of 10,000 patients will experience symptom onset more than 14 days after exposure. There is some suspicion of COVID-19 transmission from asymptomatic or mildly symptomatic patients who might be transmitting the disease 2 to 3 days prior to symptom onset, but the evidence of this is not clear. The primary method of transmission is from symptomatic patients. So let's review some basic epidemiology. R0, or R0, is the reproduction number of a disease. This is the average number of people that an infected individual transmits the disease to. The herd protection threshold, or HPT, can be calculated from R0. Herd protection threshold is the percentage of the population which has to be immune to a disease to prevent the disease from spreading. Since we don't have a vaccination for COVID-19, the only way to develop immunity is by getting the disease. Remember back when parents used to set up play dates for their children to intentionally expose them to the chickenpox so they'd get the disease while they were young and develop immunity? R0 estimations for COVID-19 vary. They typically range from 2 to 3, with a high average R0 of 2.5. The World Health Organization average for R0 for COVID-19 is 2.2, which is what we'll use here for illustration purposes. This leads to a herd protection threshold for COVID-19 of about 55 to 60% of the population. Theoretically, the disease will be eradicated after 60% of the population has recovered and developed immunity. Once the herd protection threshold has been reached, an infected patient is no longer likely to find another patient to infect. Since there is no vaccine for COVID-19, social distancing is our only choice to slow the spread of the disease, simply by limiting the number of people that an infected individual comes into contact with. If a sick person can't infect another individual, the spread of the disease slows. COVID-19 is a very significant public health challenge, but it is much less communicable than other infections such as the measles, mumps, or pertussis. This is the presumed immune response to the virus. Exposure to aerosolized COVID-19 virus leads to infection of the ACE2 receptors and alveolar cells. As I mentioned, other cells, including T lymphocytes, may also be targeted. The virus may also dampen antiviral interferon responses, resulting in uncontrolled viral replication. Remember that interferons are special warning message proteins released by infected cells as an alarm signal to warn neighboring cells to beef up their viral defenses. An influx of neutrophils, monocytes, macrophages, antibodies, and cytokines are all part of the normal inflammatory response. This is the same inflammatory response that works really well if, say, you cut your finger. However, in the lungs, inflammation can occasionally be dangerous. A cytokine storm, along with other inflammation proteins and factors, can result in large molecules on the air side of the alveoli instead of the blood side. This creates osmotic pressure, drawing liquids into the lungs. There is a lot of discussion and speculation regarding humoral immunity to coronavirus infections. Theoretically, the human immune system should develop memory cells, which can recognize a future infection and rapidly produce antibodies to protect us. However, we all know that we can be reinfected with the common cold. For some reason, the human immune system doesn't seem to retain its memory of every coronavirus infection as well as it does for other viruses like influenza or hepatitis. Some studies have suggested recent reinfection of COVID-19 patients. However, these are likely just relapses as opposed to reinfections, given the short time frame that the virus has been around. One early study completed with COVID-19 using rhesus monkeys indicated that they could not be reinfected after having had the disease. This indicates the monkeys did develop humoral immunity. There is hope that humoral immunity for humans will occur and be long-lasting, and that techniques such as plasma exchange, immunoglobulin injections, and vaccination all could be potentially viable future therapies. Protecting you, our providers, is our highest priority during the COVID-19 pandemic, so please, always wear your PPE. This photograph is an actual COVID-19 patient at the United Memorial Center in Houston, Texas, and was published by the Associated Press on Thursday, March 19, 2020. If our providers get sick, it will be difficult for us to staff the ambulance and respond to calls. N95 respirator masks are required for respiratory calls, and surgical masks are recommended for all other calls. This is an agency policy to enhance the protection of our staff. While we may need to modify this in the future if PPE stocks get low, we are maximizing protection for our providers while we can. Full encapsulating PPE must be worn for all suspected COVID-19 patients, including gown, gloves, goggles, and N95 respirator mask. It is equally important for us to do no harm and not become a vector of the disease. In Kirkland, Washington, at the Life Center Nursing Home, COVID-19 was spread for weeks by the staff. Of 120 residents at the nursing home, 34 died of COVID-19. First responders, including firefighters, EMTs, and law enforcement, were exposed and in and out of the facility and likely spreading the disease. None of us want to harm any patient, especially a large, vulnerable population like one we might find at an adult care facility in our district. Please minimize contact, especially for low acuity calls. Send in a minimum number of first responders, wear your masks, wash your hands, and wear your PPE. Why do we want to minimize first responder contact? Well, let's talk about the firefighter first responders from Kirkland, Washington Fire Station 21 who responded to the Life Center Nursing Home. 29 firefighters were quarantined after presumed exposure to COVID-19. Of the 29 quarantined firefighters, only 19 had had direct exposure to the patient. The other 10 had exposure to each other. 12 of the 29 firefighters became ill with COVID-19, and as a result, the fire station was shut down for 2 weeks. As I'm sure you can imagine, no agency can afford a shutdown like this, and no community wants to have its EMS agency or fire department shut down. So please do your best to minimize first responder and bystander contact. Proper donning and doffing of PPE is critical to protect the provider. Most contamination occurs from improper wear or improper removal. Full encapsulating PPE is required for all calls which use aerosol generating procedures, or AGP. These include use of a non-rebreather, or BVM, suctioning, CPAP, nebulizer, intubation, including RSI, and other invasive procedures, such as an oral airway. The official CDC donning and doffing procedures are illustrated here and on the next slide. The United Kingdom National Health Service recommends hand washing between each step of doffing as an extra precaution. After removing full encapsulating PPE on an AGP call, it is recommended that providers launder their uniforms, shower, and put on a clean uniform. Follow CDC and New York State DOH ambulance cleaning guidelines. Thoroughly clean the ambulance after every call. CDC recommends leaving the ambulance rear doors open so that the rig can air out while you drop the patient off. It is also a good idea to keep good airflow when using the cleaning chemicals. Wear PPE when cleaning and launder contaminated linens. Use an approved EPA cleaner for human coronavirus. Coronaviruses can survive for up to 3 days on some surfaces, so clean the stretcher, handles inside and outside of the ambulance, patient care equipment, and anything you might have touched, such as the steering wheel, radio controls, or microphone. A thorough cleaning is required for any COVID-19 patients where aerosol-generating procedures were used. Victor Farmington rigs will be cleaned again after returning to base from the hospital. Now that we've learned about the virus and personal protection, let's look at how COVID-19 patients will present. Patient assessment and scene safety begin at the doorway. Now, no doorway looks like this. but we might need to treat it like they do. Keep a 6-foot distance before patient contact. Ask questions about the patient and any bystanders to assess the situation. Is anyone symptomatic? Has anyone been in contact with a sick person recently? Decide if you and your partner need additional PPE. Also, consider methods to minimize provider and bystander exposure. Ask the patient to walk out to the stretcher if possible. Use a stair chair and have one provider wheel the patient out. During a code, use the Lucas device for compressions instead of another first responder. And if possible, have one provider load and treat the patient to minimize close contact. Here are the primary risk factors for severe COVID-19 disease and common patient symptoms. Remember, these figures should be generalized. They come from a number of different and early initial studies since the virus was first discovered in 2019. Remember, anyone of any age can get this disease. Just because a patient is in his or her 20s doesn't mean they can't become severely ill. In fact, 53% of COVID-19 cases occur in patients 18 to 49 years old. Patients with cardiac history have a 15% increased risk of severe infection and suffer a 10.5% COVID-19 fatality rate. That's more than 15 times the fatality rate for the general population. Patients with diabetes, chronic respiratory disease, hypertension, and cancer all also have increased severe infection rates and COVID fatality rates of 6 to 7%, 10 times that of the general fatality rate for the general population. Patients with no pre-existing conditions have about a 0.7% fatality rate in New York State. Comorbidities are a significant risk indicator for COVID patients. The primary symptoms for COVID-19 are fever, a cough, usually beginning with a dry cough, and in the later stages may produce sputum, and myalgia, muscle aches and pains. Fever is observed in 85 to 97% of patients. Fever is a temperature greater than 38 degrees Celsius or 100.4 degrees Fahrenheit. Fever or dry cough are often the earliest presenting symptom. Even though fever is highly likely, the fever may come and go and may not be present. So don't rule out COVID-19 just because your patient doesn't have a fever. Chest tightness is likely from some respiratory symptoms, but cardiac symptoms will need to be considered. Some recent data suggests a higher prevalence of gastrointestinal symptoms early in the disease, including diarrhea, nausea, vomiting, and stomach pain. However, I wasn't able to find any studies illustrating this at the time of publication. This illustration shows how the disease progresses in patients. Remember, these are typical numbers, but actual patient timeline can vary. People calling near symptom onset are less likely to be emergent. However, we need to find out, are they in a risk category? Have they had a serious respiratory disease before? Been previously intubated or put on a respirator? Is the patient capable of monitoring themselves and managing their illness? If you have any questions, call medical control. The majority of patients who get the disease have mild symptoms. I want to be clear on what mild means. In this case, mild means the patient doesn't have to go to the hospital. It doesn't mean that the patient won't feel very ill with flu-like symptoms. 81% of the patients will begin recovery between days 6 and 14 after onset of symptoms. Recovery may be slow, but the trend is positive. Unfortunately, about 19 or 20% of the patients with COVID-19 may experience clinical deterioration during the second week of illness. So EMS is likely to hear from patients about a week after symptom onset. Be on guard. About 3 to 5% of COVID-19 patients will be critical and in need of intensive care. These patients can rapidly deteriorate from trouble breathing to respiratory failure, ARDS, or respiratory and cardiac arrest. Here we illustrate a short summary of the most common significant diagnoses associated with COVID-19. You can use this slide as a cheat sheet. Take a moment after this training to refresh your understanding of acute respiratory distress syndrome, ARDS. This is not something we experience often, but it is more frequent with COVID-19. COVID-19 may be mild in most patients, but the disease is unforgiving of any weakness. Special attention needs to be paid to patients with sepsis or shock. And 7% of COVID patients, that's 1 out of every 15 patients admitted to the University of Louisville Hospital, required vasopressors to maintain blood pressure. For patients with COVID-19, shock kills. Other COVID-19 patients may be sick and require hospitalization, but not require intensive care. And the largest percentage of people with COVID-19 we would classify with the EMS not sick label. They'll feel lousy with flu-like symptoms, but they don't require hospitalization. This quick cheat sheet is a summary of the common abnormal vital signs associated with COVID-19. Let's highlight SpO2. Providers should review the oxygen saturation curve and the relationship between the partial pressure of oxygen and the percentage of oxygen saturation. Remember, it's the partial pressure that creates perfusion, not the saturation. Saturation is an indirect measurement of perfusion. A normally healthy patient who is less than 95% saturated is a patient whose partial pressure is no longer sufficient to support adequate perfusion. Of course, for patients who have chronic illnesses like COPD, you will find some who live with lower saturations, but this isn't normal for the healthy population. Next, let's look at capnography. Where SpO2 measurements tell us about perfusion, end-tidal capnography tells us about ventilation. The combination of these two measurements gives us a good picture of the ventilation-perfusion, or VQ mismatch, in the pre-hospital environment. Ventilation-perfusion mismatch is the key to anticipating respiratory failure and impending ARDS. Since COVID-19 is primarily a respiratory disease, we'll explore respiratory assessment further. CT scans from patients shown in the right black and white image commonly show what appears to be ground glass opacities in the lungs. Most common in the mid and basal lobes and less common in the upper field. They're about the same prevalence anteriorly, posteriorly, and laterally. The respiratory rate is one of the most easily observable indications of respiratory issues. Patient posturing, exhaustion, gasping for air, accessory muscle use are other signs. Assess perfusion, looking for things like poor color or blue lips, which are good clues that the patient has a severe VQ mismatch. Auscultate the lungs. The pie chart on the left illustrates typical lung sounds for COVID-19 patients. Crackles are the most prevalent lung sound, about 40% or so, along with coarse breath sounds. Some patients have wheezing and occasionally pleural friction sounds from inflammation and pneumonia. Recall, crackles are heard on inspiration. Fine crackles are wet popping noises, medium crackles are dry Rice Krispie sounds, and Velcro crackles have more of a rubbing or tearing continuous sound. Absent lung sounds are an ominous sign of severe pneumonia. VQ mismatch is an important indicator of impending ARDS. EMS tools for investigating VQ mismatch include examining SpO2, patients with saturation less than 95% who don't improve on 100% oxygen, that's an ominous sign. Examine end-tidal CO2. End-tidal CO2 outside the normal range indicates a ventilation problem. And a combined ventilation-perfusion mismatch, or VQ mismatch, is an ominous sign in a COVID-19 patient. Acute respiratory distress syndrome, ARDS, is not an everyday EMS call for us, but unfortunately is more common in COVID-19. About 5% of COVID-19 patients will get ARDS. Acute respiratory distress syndrome is an ominous sign in any patient, and this is particularly true for COVID-19. ARDS often develops over 2 to 3 days, beginning with shortness of breath, but onset can occur suddenly in COVID-19 patients. ARDS results from inflammatory proteins and infiltrates moving into the alveolar space, increasing osmotic pressure and drawing water into the lungs. Damage to the alveolar epithelium may also make the lungs more leaky. Oxygen gets stuck in the airway, carbon dioxide stuck in the blood. This results in the ventilation-perfusion mismatch. Oxygen goes into the lungs but can't get into the blood, and carbon dioxide can't get from the blood into the lungs. Two big diagnostic clues are saturation is increased to 100% via NRB, but SpO2 doesn't increase or only increases marginally, and end-tidal CO2 is less than 35 millimeters of mercury. The patient can't get carbon dioxide out. These patients will present similar to a congestive heart failure patient, except common CHF indicators, such as edema, may not be present. These patients require emergent treatment to correct the VQ mismatch using PEEP, nitroglycerin, or both. Be cautious observing patient presentation. Early patients may exhibit a high respiratory rate, where exhausted late-stage patients may not. Patients early in the process may exhibit high end-tidal CO2, over 45 millimeters of mercury. These patients still have some lung capacity to get rid of CO2, but since that capacity is insufficient, the patients are hypercapnic. Onset of ARDS can be sudden, dramatic, and fatal. Keep a high index of suspicion with COVID-19 patients, especially patients with comorbidities and patients in their second week of illness who haven't been improving. This is a summary protocol for COVID-19 patient assessment. Use your knowledge and clinical judgment to understand and appreciate this protocol. Is the patient sick or not sick? Remember, respiratory patients require N95s, and any aerosol-generating procedure requires both N95 and full PPE protection. Transport sick patients and call ahead to notify the receiving hospital. If a patient doesn't require transport, try to convince them to stay home and contact their personal physician or the U of R or New York State Department of Health information lines. Contact medical control for a patient who doesn't consent and wants transport. Remember to get a sign-off and thoroughly document any patients who do not transport. Victor Farmington will be putting copies of the New York State advice for non-transports in the rigs. The pediatric population for COVID-19 during the initial outbreak in Wuhan, China was approximately 13%. In Western countries, a 2% pediatric caseload appears to be more typical. This is similar to the SARS and MERS outbreaks, where the majority of cases were limited to adults. It is still important to maintain a good index of suspicion for pediatric patients. If a pediatric patient looks sick, has a life-threatening event, or is having difficulty breathing, they need treatment, whether or not it's COVID-19. Remember to wear PPE for the kids. They'll appear to have a run-of-the-mill childhood respiratory illness with cough, congestion, runny nose, sore throat, and maybe a fever, but they could be highly infective with COVID-19. Since this disease has only been around for 4 or 5 months, we really don't know a lot about how it might affect a 9-month pregnancy. There is little known about risk to obstetric patients. Recall the normal physiological changes in disease risks associated with pregnancy, such as increase in blood volume, but a decrease in hematocrit. There are no known issues at this time for the baby in utero and no known vertical infections, but data is lacking. Next, we'll review treatment protocols applicable to COVID-19 patients and discuss some modifications and considerations. Some of these protocol changes will require provider judgment. Remember, you can always phone a friend and consult with medical control. You're not alone. We're still practicing good emergency medicine. Begin with a doorway assessment and move on to ABCs, sample, and OPQRST. Treat emergent life threats first, using our usual protocols. If someone's bleeding, stop it. If a suspected COVID patient is complaining of chest pain, a 12-lead EKG and the cardiac chest pain protocols are in order. BG is important because of the significant risk diabetes plays in COVID-19. Sepsis is a significant mortality factor for COVID-19. 49% of COVID-19 patients presenting with sepsis and pneumonia ultimately die from multiple organ failure. Lungs are already compromised, so remember to frequently reassess lung sounds during fluid challenges for COVID-19 patients. And recall Louisville, Kentucky, where 7% of COVID patients were hypotensive enough to require vasopressors to maintain blood pressure. This is an example of a drug we may not use often, but could be beneficial, so keep vasopressors in mind. Fever. There's evidence that prolonged use of NSAIDs may negatively impact the recovery rate from COVID-19 and other viral diseases. Ibuprofen, Motrin, is contraindicated for suspected COVID-19 patients. If it is necessary to treat fever, acetaminophen, Tylenol, is preferred. Some COVID-19 patients have GI symptoms, so remember ondansetron, Zofran, for nausea. And remember to call the hospital ahead if you're bringing them a suspected COVID-19 patient. Minimize the use of aerosol-generating procedures. Use a conservative approach for patients who are not in respiratory distress. This will require good clinical judgment. Is it worth potentially spreading the virus? Is the patient sick or not sick? Use a nasal cannula when possible. Defer nebulizer use. And if it is necessary to neb, use a non-rebreather mask instead of the traditional handheld cigar-style nebulizer. Use of dexamethasone, Decadron, or magnesium sulfate early for asthma patients, even before nebulized medication. There is evidence that use of steroids is potentially harmful to COVID-19 patients. This is one of those cases where provider judgment may be needed. If a patient is having severe shortness of breath, the short-term benefit of steroids likely outweighs the long-term risk. Consult medical control for early guidance, and remember to notify the receiving hospital of a suspected COVID-19 patient and any significant respiratory symptoms. Early intubation for COVID-19 patients in respiratory distress or respiratory failure saves lives. Only 1/4 of the patients who died in Wuhan, China, received mechanical ventilation. Maintain a focus on high-risk patients greater than 60 years old and patients with comorbidities. It is highly recommended to use video laryngoscopy and have an experienced or the best airway person intubate to increase first-pass success and reduce risk for everyone. It is also recommended to minimize the personnel present when intubation is conducted. 2 providers in the ambulance or on scene should be sufficient. Don't expose any more people than necessary. Aggressive pre-oxygenation is recommended. Patients are likely already to have compromised perfusion and could desaturate faster than normally anticipated. Use PEEP after intubating to help correct VQ mismatch. Full encapsulating PPE is mandatory for intubation and any aerosol-generating procedure. Consider RSI early. Call early for patients who are very sick. Preferred drugs for COVID-19 RSI are rocuronium and ketamine, which have a lower chance of contradictions or side effects, especially for patients with comorbidities. So let's review. COVID-19 is a severe respiratory disease for 1 out of every 5 or so patients who get it. The infection is expected to reach about 60% or so of the population over time, and the disease can infect anyone of any age. COVID-19 is most severe in patients greater than 70 and patients with comorbidities. These patients may decline rapidly. Please take a moment to review proper PPE use and hand washing. The signs and symptoms of COVID-19 and ARDS. Indications for rapid sequence intubation. Respiratory protocols, treatments, and medications, especially the pulmonary edema protocol. Locations of respiratory equipment in ambulances and fly cars. Nebulizer treatment using a non-rebreather mask. The use of CPAP, which, although we prefer to avoid, may be necessary, and the use of PEEP valves. Wear your PPE. Minimize exposure. Wash your hands. Clean the rig. Be familiar with the presentation of patients with COVID-19. Be able to differentiate between sick and not sick patients. Conservative respiratory support is preferred for most patients to reduce aerosol generation and risk to providers and bystanders. Avoid aerosol-generating procedures if possible. Be prepared to provide aggressive respiratory support to patients who are in respiratory distress or respiratory failure. Video laryngoscopy intubation early by an experienced provider saves lives. Consider RSI early for patients with ominous signs and symptoms. Acetaminophen, Tylenol, is preferred for fever. Ibuprofen is contraindicated for COVID-19 patients. Carefully consider the use of dexamethasone, Decadron, for COVID-19 patients. Consult medical control early and provide early notification to the hospital of a suspected COVID-19 patient. Victor Farmington Volunteer Ambulance is doing everything our agency can to prepare for COVID-19. Agency leadership is coordinating emergency activities with the Town of Victor, Town of Farmington, Village of Victor, our state representatives, and local fire agencies. Victor Farmington has increased our supply of masks, equipment, medications, and cleaning materials as best as possible to prepare for COVID-19 in our region. Our commitment to protecting our providers and patients is enhanced during the COVID-19 pandemic. COVID-19 is a significant public health challenge. Let's do everything we can as providers to prepare, take care of ourselves, take care of each other, and be ready to care for our community. Thank you.